Good morning, everybody. First of all, I thank Dr. Gaurav for starting very well. Now, I'll be covering ultrasound of the peripheral nerves, which is the unused modality and which is the best modality available right now for the evaluation of the peripheral nerves. So, the basic ultrasound is ultrasound technology, how it is to be done, and then we'll have a discussion of cases. The nerve fibers that are containing axons, myelin sheath, and Schwann cells, they are grouped together to form fascicles, and loose connective tissue like elastic fibers and vessels that surround it, it is called as sheath perineurium, and thin septa arising from the perineurium that spreads into the fascicles surrounding every single nerve fiber, that is called as endoneurium, and all these are bundled out by outer covering epineurium. So this is a schematic image. Of the nerve, peripheral nerve. These are the fascicles, and this is the endoneurium, and this is the epineurium. And the same picture is seen on ultrasound. So these are hypoechoic are the nerve fascicles, and surrounding are the epineurium, perineurium. So the normal ultrasound is closely resembles histological aspect. You can see the video which is showing the median nerve, the nerve fibers, and adjacent are the muscle fibers. So how to evaluate the peripheral nerves on ultrasound? Usually you have to have a high frequency peripheral transducer. 8 to 18 megahertz linear probe should be used. Visualization of the peripheral nerve should always be starting from the skin surface, which is a known anatomic landmark, like wrist, flexor retinaculum, or in the knee joint. You can always start from the known point, and then you can move the transducer to and fro. The nerves are seen as parallel hyperechoic lines with hypoechoic separations in between, and they almost look like muscle fibers. But in muscle fibers, there is discontinuation of the discontinuation, while the nerves will show continuous fibers. So this is the median nerve in the transverse section, and this is the median nerve in the longitudinal section, and this is the muscle fibers that adjacent to it. You can see that there is discontinuity while the nerve fibers are showing continuity. The same picture, static image. Now, various nerve pathologies that can be diagnosed and on ultrasound are nerve injury, neuropathies, or that is compression neuropathies, tumors, and infective pathologies of the peripheral nerves. So, nerve injury. There are three different varieties grading of the nerve injury. The first and less grievous is the neuropraxia, where there is minor contusion or compression with preserved myelin sheath. Usually, it has a very good recovery. Then axonotrophomosis, that is the partial breakdown of axon and myelin degeneration can occur, but there is a preservance of the Schwann cells and endoneurium, so moderate regeneration is possible. But in cases of neurotmesis, where there is actual avulsion injury of the nerve fibers, there is anatomical severance, avulsion or crushing injury to the nerve and Schwann cells and endoneurium. Usually it requires surgery. So ultrasound will give information about which nerve is involved, at what level it is involved, the cause and the nature of the injury, and the degree of injury, whether it is old or fresh, whether the nerve fibers are in continuity or there is some disruption, and it will also evaluate the cause of compression. If at all there is a foreign body, as shown by Dr. Gaurav, you can detect it and you can remove it, and the patient will have good results. And it will also give information about the distance between the two stumps, which will decide about the length of the nerve graft that can be diagnosed, and it will be very helpful for the surgeon. And also it will give information about the stump neuroma, as Dr. Gaurav has shown on one case. So this is a case where there is a radial nerve which is seen. The fibers are seen in continuity, and this is the muscle fibers. This is in continuation. This is normal nerve, and this is edematous nerve fibers, and there is an injury to the radial nerve. So this is a minor variety. It usually has a good recovery. And in this case, there is a large hematoma, and there is partial involvement of the peripheral nerve fibers over here. And in this case, there is a injury to the muscle nerve fibers, and there is partial discontinuation. In this case you are seeing it. And this is a severe case in which you are seeing a discontinuation of the nerve fibers. This is avulsion injury, crushing injury, there is discontinuation. This much length is discontinued. So you can measure the distance, and this will help in the surgeon to decide about the management. The same another case which is showing injury to the peripheral nerve. And again, after a few months, you can have a neuroma formation. That is because of injury. Localized dilatation of the nerve, the endings is well seen, and there will be degeneration, and the rest of the nerve fibers are well seen. So this is the normal nerve in transverse section. Near the injury site, it is showing edematous, and size of the nerve has increased. And lower down, it is further increased, and there is a neuroma formation is going on. So this is a recent case. There is injury to the ulnar nerve, and this is the ligament of Osborn, which is also thickened, and you can see there is a ulnar nerve which is peripherally, it is showing echogenicity and enlargement at the level of elbow. This was just a few days back we did this study. The video is not working, but it will show the subluxation of the ulnar nerve in this image. This is the ulnar nerve, which is edematous. There is another case which is showing injury to the vessel and the pseudoaneurysm formation, and it is compressing the median nerve at this level. This is another case where there is a complete tear, small segment of the tear into the injury site of the ulnar nerve. This is again another case where there is an injury to the muscle fibers and partial injury to the nerve fibers also. Now coming to entrapment neuropathies. Entrapment or compression neuropathies are often unrecognized cause of pain and neural impairment. The nerves are more prone to compression in specific locations where they course through osteofibrous tunnels. That is commonly in carpal tunnel, you get the median nerve compression, in ulnar nerve, in Guyon's canal, which is getting compressed, and the common peroneal nerve near the fibular neck, and the posterior tibial nerve in the tarsal tunnel. Compression of median nerve between carpal bones and flexor retinaculum is the commonest pathology that we come across in our day-to-day practice. There will be focal enlargement proximally and the flattening distally. This is the most diagnostic criteria. The cross-sectional area of 10 square millimeter is abnormal with abrupt narrowing distally. This is the most diagnostic change. And enlargement of more than 2 millimeter in cross-sectional area as compared to the proximal or distal segment is also 100% diagnostic accuracy. Nerve flattening should be regarded as a main sign of compression. There will be reduced nerve mobility on compressed side. The axon loss may be associated with enlargement due to endoneural edema, and there will be loss of fascicular pattern in subsequent period. So all this can be diagnosed on ultrasound. So this is a case where this is the median nerve. You can very well see, and you can see the measurements. And this is the site where it is showing compression. This is the distal dilatation. This is the normal nerve, and this is the compression nerve. And you can always compare with the opposite side. This is the right, which is the normal side, and this is the left, which is showing compression. And you can compare with the measurements. This is the compression side. This is more than 10 millimeters. This is the area. Now coming to infections, the viral infections and leprosy are the common infections that can be diagnosed on ultrasound. There is a focal dilatation of the nerve. The nerve fibers are edematous, and subsequently there will be dilatation, and this is seen at the length This is normal now, and here there is a focal dilation at the ulnar now, at the level of elbow. This is again normal now, local dilatation. This is also a known case of leprosy. Now coming to nerves, peripheral nerve tumors are common. They are common. Nerve tumors are the commonest. They are known as schwannomas or neurofibromas. Schwannomas have eccentric length extending along the long axis of the fascicles, and neurofibromas are spindle-shaped with loss of normal fascicular architecture. Color Doppler will definitely help in these cases. Color Doppler will show some vascularity in neurofibromas, whereas schwannomas will not show vascularity. Then it can be malignant hemangiomas, lymphomas, extending soft tissue, which are encasing the nerve, that can be diagnosed on ultrasound, which may not be possible on MRI. This is a case where the posterior tibial nerve is showing, and this is a large cystic lesion, which is involving the peripheral nerve sheath. This is the tumor, and is compressing the patient was having foot drop. And on ultrasound guidance, we took the biopsy from this mass lesion. Then few tumors like lipofibromas were very rare tumors. There is focal dilatation. It just looks like in carpal tunnel syndrome, but these are more hypoechoic fat depositions are seen. So ultrasound is a very good advantages. It is most important is inexpensive. It is widely available. There is no contraindications. You can do all patients. It allows rapid and detailed imaging of the entire length of the major peripheral nerves, and you can always compare on the both sides. It is definitely far superior than MRI because of its dynamicity and versatility. It can be moved from segment to segment, and comparison of contralateral side is always possible, which may not be possible on MRI. Thus, ultrasound is a useful modality in the evaluation of almost all the peripheral nerve pathologies. The lack of awareness about the potential of ultrasound in the form of that referring clinicians do not understand it easily, and the lack of expertise have led to MRI being favored over ultrasound. But in coming days, it will definitely be overcome by newer radiologists who are taking more interest in musculoskeletal ultrasound. Definitely that will improve the scenario. So in our country, with the majority of population which is unable to afford costly diagnostic tests like MRI, ultrasound should be the first modality, but still it is underutilized modality. Zeidman et al. Have reported that ultrasound has a higher sensitivity and equivalent specificity as compared to MRI, and it also detects multifocal nerve lesions better than MRI. They go on to say that ultrasound is a preferred initial modality in the anatomic evaluation of suspected peripheral nerve lesions on ultrasound. Making the referring clinicians aware of its possibilities, proper labeling of images along with panoramic views, and adequate training of the radiologists are the steps in the right direction. And Dr. Gaurav is one of the pioneers of musculoskeletal ultrasound. He will be visiting most probably for doing musculoskeletal ultrasound as well as interventions in Aurangabad. We are hoping him to see again. Thank you very much. I acknowledge my images for Shanti Imaging and MGM Medical College.
No, brain body is not possible. Only peripheral nerves which are showing some thickness, but specific location-wise, you can definitely show that there is a sensation between the nerves. Yes.
The better, higher frequency images are better because you can see the superficial structures very well on a higher frequency probes. Yes. So, yes. That's why such interactions are more needed. If you come across, then we can send the live images also if you want. Live images, you can see the entire video, you can see the entire length of the nerve, muscle, fibers, where discontinuation is there. that can be seen. And definitely with the interactions between the clinicians and the radiologists, it will improve both ways. Thank you very much.